Now we are going to study about essential infantile esotropia, early onset, high risk of amblyopia, large angle, 30 prism diopter, free alternation, cross fixation in alternator and fixating performance of normal eye in amblyopias. No significant refractive error, no neurological defect, confirmed only after 4 to 6 months. This is a picture is showing by infantile esotropia. May be associated with IOA nystagmus and DVD. Asymmetrical optokinetic nystagmus, temporal to nasal, smooth, nasal to temporal. And special characters of congenital esotropia is OKN asystemic, a temporal to nasal, smooth following and rapid refixation, nasal to temporal, jerky inaccurate movements with a halting inflation. OKN asymmetrical is presented in all infantile but becomes asymmetrical by 6 months. Patients with congenital ET OKN asymmetrical. Variant of essential infantile esotropia, senescence symptoms and lag symptoms. Senescence symptoms is early onset ET, bilateral adduction limitation, manifest latent jerk nystagmus, fast phase in direction of fixating eye, increase in adduction, decrease in adaptation, phase turn towards fixating eye, fixating eye is adduction, null point is adducting. Lag syndrome, early onset ET, DVD, nystagmus, exocular deviations of non-fixating eye may be associated with transverse. Different diagnosis: cranial nerve 6 paralysis, dull eye monovius, Down's retraction syndrome, change in palpebral aperture, upshoot, downshoot, and on adduction, CNS anomalies, Down syndrome, cerebral paralysis, accommodative ET, paralysis accommodative ET is cycloplegic refraction. Nystagmus blockage syndromes is inverse relation between amplitude of a nystagmus and degree of etiology unknown. Multiple factorial heritable factor, monozygotic twins showing esotropia. Development anomalies seen first 4 months. Management depending on the treatment of amblyopia, full cycloplegic refraction under atropine 1% eye ointment, full hyperopic correction, occlusion therapy, conversion full time, fully opaque occlusions of dominant eye. At no point during the treatment is binocular viewing allowed. Thus, the patching is done for 1:1, 4:1 or 5:1 day for a 3, 4 or a 5 years old child represented. Above 6 years, the remaining 6:1 for all age. Vision assessment and monthly. Endpoint is freely alternation of a 2 eyes which is equally maintained. Surgery large angle ET is earliest 4 months of age. Small angle ET is proper hyperopic corrections till 6 months and till examination can be done satisfactorily. Factors to be considered: associated inferior oblique V phenomena, amblyopic therapy, DVD, nystagmus and encentrical fixation or uncorrected amblyopic having unpredictable result. Surgical guidelines: MR, medial rectus surgery is more effective than lateral rectus surgery. Monocular resection, resection and sections of by medical resection, and MR 1 mm surgery corrected 3 to 3.5 prism diopter of deviation. Lateral rectus is 1 mm surgery correction is 2 to 3 prism diopter of deviation. Acquired or latent onset of non-accommodative esotropia is onset after infancy. No accommodative factors and no neurological cause. Acquired essential no accommodative esotropia, basic type or convergence excessive type. Rarely, deviation insufficiency may be present. Management surgery with better binocular vision potential than infantile esotropia, microtropia, and ultra small angle ET missing by ordinary method of examination usually have amblyopia on one eye with a variable level of binocularity, primary and secondary. And prang monofixation syndromes is monoscotoma, good peripheral fusion with fusional amplitude and cross stereopsis. Lag microtropia is small angle is less than 5 degree heterotropia, harmonious ARC, mild amblyopia and parallel stereopsis, basic fixation pattern and cover test. First three types. First one, type 1 central fixation zootropia. Second one, encentrical fixation without identity is zootropia. And third type is encentrical fixation with identity does not pick up atropia. Type 3 is encentrical fixation with identity implies that angle of anomaly is same as a eccentricity of fixation. Finding in microtropia, consistency and variability, amblyopia consistency is amblyopia ARC relative scotoma on fixation spot, normal and or near normal fusion amplitude, defective stereo acuity. Variable size of deviation is 5 degree to 8 degree, foveal and non-foveal fixation. Relationship between the degree of encentrical fixation and angle of anomaly. Presence or absence of anisometropia, positive or negative cover test. Diagnose macular scotoma is Boligen glass or 4 diopter prism diopter test. Presence of amblyopia and associated refractive error should be detected. Management treat amblyopia with occlusion therapy and good prognosis if treatment is younger children. An acquired convenient esotropia, sudden presentation, combined diplopia. Two types, those with the manifest after a fusion have been interrupted by the patch or occlusion for a short time. Those with having a no such interrupted to fusion but having a very poor fusional control, which may be further compromised by physical and emotional stress. First type is spontaneous resolve within 6 months. Second type is surgery prismatic neutralization in case of small angle of ET. Cyclic esotropia. Irregular cyclic is presented usually 24 to 48 hours of squint alternation with same duration of no squint, squint day, large area ET, sensory anomaly, squint of consistent. No squint day days is BSV is with good fusional amplitude, no latent squint. Last for a few months, 2 years before they become a fully manifest squint. Surgery as per deviations on squinting day giving satisfaction result. Nystagmus blockage syndrome. Infantile ET is associated with manifest latent and latent nystagmus. However, there is a special form of nystagmus which has a dampening mechanism with eyes in adduction. Inverse relationship between ET and nystagmus. Nystagmus is present when eyes are straight and it disappears when eyes are look in ET. Management faded with or without BLMR resection. Sensory esotropia, loss of vision, loss of vision in one eye usually develops squint over a period of time. XT and ET depending on a convergence turns. And ET is the first year, and after 8 to 9 years of age, ET is after first year up to 6 to 9 years of age. Refractive error and accommodative state of the straight eye need to be evaluated before planning any cosmetic surgery. Thank you.